this really nice meeting space, and we really appreciate it. So what I'd like to do is start off with some introductions quickly. And first, though, I want to share with the people on the phone, the work group members that are on the phone. So you'll be unmuted, and you can introduce yourself and let us know you're there.
Hi, this is Jeff Richardson.
Hi, Jeff.
Hi, Baranek.
Hi, it's Joe Torito from Kaiser Permanente.
Karen Muswak, are you there? I heard Karen earlier, so I'm reasonably, she's on the webinar, and I'm sure she'll be engaging in the conversation. So with that, we can go ahead and start and move around the room. You know, I'm Diane with the Health Services Cost Review Commission.
Shreya Cholakola with HSCRC.
Allison Schuster, HSCRC.
Elsa Highland, HSCRC.
Bobby Sabi, Mid-Atlantic Permanente Medical Group.
Andy Udom, HSCRC.
Beverly Miller, Maryland Hospital Association.
Justin Dybel, Mercy Medical Center.
I'm Tracy Laval from the Maryland Hospital Association.
Rosemary Murphy, Department of Health and Mental Hygiene and Medicaid Program. Barbara Abke, Vice President, Lifebridge Health. Madeline J. Delmarva Foundation.
Miriam Ramon, attending for Tressoli, Maryland Healthcare Commission.
Dan Cochran, CFO for Shady Grove Adventist Hospital.
I'm Tom Dallek. I'm a partner with Discern Health, subcontracting to Burton Policy Consulting, contracting to the HSCRC staff.
And I'm Rob Cohen. I'm a consultant for the HSCRC staff.
In particular, what I wanted to ask with Tom on the first meeting, first substantive spot here, what I'd like to do is ask you to say that since Tom's actually going to be really very closely working with the performance management work group in particular, he's assigned to helping us get work through our process, get to the decision points and the recommendations that we like to get to through the course of our work. So if you could tell us a little bit about your journey, and
Sure.
I think people would really appreciate it.
Thanks, Diane. So again, my name is Tom Dallek. I'm a partner with Discern Health, a consulting firm in Baltimore that really focuses in on quality and the use of quality measurement information for things like payment and public reporting and improvement. My background, I joined Discern about 4 months ago, but before that I was with the National Quality Forum for the last 4.5 years, working on advising the federal government on the use of measures for the various Medicare programs, now over 20 of them, that use measures for the purposes of payment or public reporting, or at least gathering information at this point in what we call the building blocks for value-based purchasing. Prior to joining NQF, I was with the Centers for Medicare and Medicaid Services for 4 years, working on the early implementation of the various value-based purchasing models. I'm a physician and also a former hospital executive. I was a VP Medical Affairs at the University of Kansas before coming to Washington and getting engaged in health policy. Looking forward to being a part of the discussion.
I want to ask for people on the phone if you're able to hear the conversation.
I can hear.
Yes, I can hear it's a little muffled, but it's okay.
Okay, so we'll ask people to project. I will project as well. So I also did Bill Holman mention that he's is Ryan Mutter on the webinar?
Yep, I think I might have been muted before. Sorry, I introduced myself, and you guys must not have heard me. Hello.
Great. All right. Thank you so much. Okay. I think, well, I'll just talk about the agenda for 30 seconds. We're going to first do a recap. Shulay will do a recap, then we'll discuss from the last meeting, and then we'll discuss the readmission target. And then MHA will do a presentation on an alternative Maryland Hospital Chart Conditions methodology, and then we'll go and discuss potentially avoidable utilization. And so with that, I'm going to put the slides on for the readmission target.
Good afternoon again. So in terms of the recap, as you know, we had a very full presentation in the last meeting, and Allison did, I think, a great job in recapping and kind of detailing some of those issues that we discussed. So what we are going to do is we're going to pick it up first with the readmission targets. There's going to be some repetition, and then really going into detail and thinking about what will be the national projection, what should be our target for Medicare, and then I'm going to talk about some of the other issues that we started discussing in the last meeting. So in terms of the first meeting discussions, as we all remember, the goal is to reach the national Medicare target by the end of the 5-year period, and we will be using the CMS measure of readmission. And we confirmed with CMS that this is the same type of measurement that they use for Partnership for Patients program. So if you are familiar with it, we are going to be using the exact specs that they do have in that program. And just to get us oriented, in the last meeting we presented you a scenario where we were looking at 5 years down the line. But again, our focus for this initial meeting, given the timelines, is really for calendar year 2014. What we can do quickly that we all feel comfortable that will have an impact easily on the readmission rate for 2014, and then we'll pick up what we decide here for probably late summer to kind of really think about, okay, for 15, what we can do to make it better. So I think it's really unrealistic to expect that we're going to solve all the issues related to readmission or the target in a matter of 2 to 3 meetings. I think we kind of need more time to think about this in the long term. So I wanted to make sure that our expectations and concerns are kind of clarified, and hopefully that will ease some of the tension if you are feeling.
And it's early to interrupt you to make a comment. But first of all, I absolutely agree with that. The second thing is, I just want to point out that while we may be clear on what we know for the present time in the national initiative, I'm really not clear. Maybe others are, I'm not, on going forward where we're going. So it will be really important for us to stay somewhat in step with that process. And if we don't know it, we really can't go beyond here. So I do appreciate that comment. I just wanted to point out, because I would imagine most of the group like me doesn't know what the future is for direct education.
And that's very actually important.
Right, and we have something in the slide that sort of portends your comment, the input from Amy Boutwell on that, just that. So great. That will be good.
So jumping right into the numbers, so what we did is we changed the models that we presented to only just for 1 year, what we say is reasonable for the first year. So in this table, we also put the national Medicare historical trend. So if you concentrate on the percent change column on the national Medicare, you see that in fiscal year 2011, there was a 0.2% increase in the readmission rate. And then in the last 2 years, you see a decline in a faster rate. So in fiscal year 12, the national Medicare readmission rate declined by 1.3%, and in fiscal year 13, we see a 3.7% decline. So again, what we discussed, the denominator issue is in effect, but at the end, our target is what it is. So at this point, we are really looking at that rate without really going into too much detail about why we observe that change. Comparatively, we've been doing actually much better than the national change, if you see it. So we had almost 2% decline in fiscal year 11, 3% almost for 12, and then 5.5% in fiscal year 2013. And I think we can credit some of it to the ARR program, and of course the implementation side, the efforts in the collaborative, and also, as you know, CMS is funding some of the community-based initiatives through Delmarva Foundation too. So I think it's probably a combination of all these factors impacting this. So in this scenario one, what we assumed is, okay, if in fiscal year 2014, the national Medicare goes down as they did in fiscal year 2013. So if they go down by 3.7%, what will be required for Maryland to go down? And here, the 5.5% is a 3.7% national, so we need to match that rate. And then we have a gap between 18%, 17.6% in 13, and 19% for Maryland, right? There is a gap that we need to also catch up. Simplistically, what we did is we took the difference between those two rates and divided by 5. If you assume incrementally we are closing that gap on a linear basis every year, this is the minimum reduction that we need to have in the Maryland. So it's 5.5%. Then the calendar year target is, as you know, in the readmission program, our performance is going to be calendar year 2014, and our base year is fiscal year 13. So we added the that extra six-month gap because of the data issues to estimate. If you put this in the program as a target, then the target will be at 8.2% on an 18-month basis rather than an annual decline of 5.5%. Any questions so far on this? You can always interrupt me.
And folks on the webinar can raise your hand, and you can do a chat question, and we have someone monitoring that.
So in scenario 2, what we said, instead of 3.7, since the national decline seems to be increasing, we modeled it the same methodology with 5% decline in the national estimate. And that got us to 10% Medicare decline required for the Maryland for the 18-month period.
I just want to make sure I'm following this well. The purpose of scenario 1 versus scenario 2 is comparison of logic. Just tell me what the difference is in your mind between scenario 1 and scenario 2 in terms of why we're looking at that. Are you feeling scenario 2 is more accurate based on what you've seen so far? 10% is such a large number.
Right. So I think if you look at the trend, 1.3% and then 3.7%, most likely if it continues, you would expect the decline to be bigger than 3.7%. I think it's conservative to estimate that the decline is going to be at 3.7%. So the question is how much that we want to build as a buffer zone, and 5% was kind of my round number to it. And really what you need to compare 5% to is 6.7% on an annual basis. That six-month gap is really the data lag issue, and we may have already done that. When we get the data, we'll see, since we've been continually declining too. So the annual reduction there, 6.7, is really the comparative percent for the 5%. So we may get some more feedback in terms of where that percent point decline for the national should be, but I think clearly I would feel very uncomfortable making it at 3.7%. It should be something higher than that.
A question from Ryan Leonard. Have you considered including revisits for observation, i.e. recidivism, in your readmission measure? One of the likely reasons for the decline in the readmission rate is the increased use of observation. If you exclude observation, you could see a decline in the readmission without the use of hospital services with declining.
Very good point. So I listed that as one of the topics that I would like to open the floor to discussion maybe a little bit more. I think that's one of the major concerns we have. And not only in terms of hospital views and the target, but also leveling the playing field for the hospital, because there is a tremendous variation in the way hospitals are using observation. And ideally, I think you would want to take that into account when you calculate these readmission rates.
In order to take it into account for what we're looking at, we would have to understand how CMS is taking account of the Medicare number nationwide, because that's what we're comparing to. So if we don't know how it's being handled nationwide, I think it would be difficult to carve it out in the state.
I love you. That's great. Because that's what I now that we're having, because you have an inpatient readmission target. That's done. They are not going to take into account observation. That's done. You have to match that. But programmatically, we have an issue with the observation. So how do we integrate those together? So for sure, we have to hit the inpatient. And from a very a narrow and crude way of thinking, in terms of if I'm just thinking about the target, I wouldn't care too much about the observation, really. But from a policy implementation perspective, from the impact on the patient, I care tremendously about the observation. So I think we need to think about setting these targets on the inpatient side, but also probably building some kind of a buffer or a protection to take into account the observation. So I think if we think about these two dynamics, targeting inpatient and observation, I think that will be really helpful. So that's the last bullet that I had, so maybe I should have had that in the first one that we discussed. The other issues with the target data that we discussed before, some adjustments if we take this target and try to do it on the hospital level. Obviously, at the state level, it didn't matter too much for risk adjustment compared to the national, because the risk adjustment is still developing, and at the kind of comparative to the national one, CMS says you got to get to the national average. You may have some different populations, but it shouldn't impact as much. You do have a high readmission rate, which we agree. At the hospital level, though, when you try to get some targets for them, then planned admissions and the risk adjustments are the two important things that I think we need to consider in terms of adjustment. And here, a new discussion that we would like your input on is when we do risk adjustment, whether we use a discharge VRG or an admission VRG. The difference between those two are the discharge VRG takes into account all the ICD-9 codes, regardless of whether they were present on admission or something happened during the hospital. The admission VRG, and those of you who are working in MPAC and mortality are very familiar, is the VRGs that patients come with to the hospital. So the potentially preventable complications that are occurring during the stay are not taken into account in the admission VRG. So in terms of trying to make the adjustments equally between hospitals and also aligning the measurement with other quality programs, we think that it may be more reasonable to do admission VRG adjustment rather than using a discharge VRG. Discharge VRG, we've been using it for case mix adjustments because of the resource use. Whereas the admission VRG is kind of controlling the factors that might be related to quality, and you may not want to give too much credit if there are things happening during the hospital stay that is impacting that VRG. On average, there is a 5% difference between admission and discharge VRG, so it's not that big impact, but nonetheless, it may change a few hospitals, and it may also have implications in terms of versions that we use in the HRVRG world. Any discussion or question on that? Then the other issue that...
What does Medicare use?
They are using discharge VRG.
So why wouldn't we use discharge VRG? I mean, don't we want the methodologies to match?
Because actually in the Medicare target, we don't have any risk adjustment. So we are flexible in terms of what we can use in our measurement. And the hospital-wide readmission rate adjustment is very different than what we usually do. So they break down they have different models for different disease classification, so one model for psychiatric patients, one model for cardiovascular, and then I believe they take into account the physician claims to really risk adjust all those models. So our risk adjustment is fluid still, even if you do case mix adjustment, it's not fully accounting for all the factors, I believe, but it's making it adjusting for the case mix differences between hospitals.
Okay. But before you move on from the numbers, can I ask a question about the numbers that you showed on the chart? It looks to me like, and I'll start with scenario 1, I guess. They're relatively close, but it looks to me like the difference between where Maryland is in fiscal 13, 19.21% versus 17.66, which is the nation, is about 1.55%. And it seems like we have to bridge that gap over a 5-year period. So a couple points, I guess. One is obviously the target is heavily dependent on what you assume for the nation. And in your 2 scenarios, you assume 3, 7, 6, and 5, one of which is derived from the most recent year's actual. I guess it's hard to argue. But my question is, as you've laid out the target in calendar year 14, the difference between Maryland and the nation at 17.62 and 16.66 goes all the way down to 0.96, which is a change of 0.59, and at the risk of getting into the numbers too much, that's actually like more than a third of the change. If you're spreading it over 5 years, we really have to get like 20% of the change as opposed to 38% of the change. Is there a reason why you're front-end loading the gap so much?
So it's not too much about the front loading. That's the difference between if you use the percent, if you take the percentage point difference, which is linear versus the percent difference. So you code it as 1.5 as a percentage point difference, and you're assuming that's going to be linearly for 5 years. In the model, what I did is I calculate the percent difference between 19 and 17%, which is
you're taking the percent of a percent.
Right.
Okay.
So that's the only difference. If you do it that way, then you have much lower, slightly lower one, but not that much difference. So the compounding effect of those percents are impacting the way we do the calculation.
And is that an intended impact, or is that a byproduct of the calculation?
So in my logic, it's a byproduct of the calculation by my logic, but since we are predicting percent change for the national at 3.7% of the 17%, I kind of use the same scale, if you will, to compute the differences between national and the Medicare. So it's a math problem, and we can do the similar calculation using percentage points, and the numbers are kind of coming around the same percentages, except the difference between national and Medicare.
Okay, so maybe the group can consider that at some point, whether we want to use a percent of a percent or whether we want to use just a straight math issue. Because it has to do with how quickly you're getting to that state average number. I think it's important for setting the target, as well as obviously what we assume for the nation. I don't know if you're just throwing these 2 scenarios out for discussion or if you're proposing one of them or whatever, but
what I'm just saying is, so this is kind of the scenario 1 is baseline. And then I think, or it may not be. If you think that maybe we should take the average of the 2 years, but I feel like we have pressure, really, to catch up to the national average, and we need to be less conservative in setting these targets rather than trying to do an average and lower this. I think it's safe to assume at least 3% for the next year.
I just want to make a comment that is somewhat linked to the comments just made. I did a lot of thinking about the front loading as well, because I was looking at the patterns at the national level. The rate of decline was slower at first, it seems, at the Medicare level. And my concern is looking at the various pieces that we talked about at the last meeting, PDR, MDAC, PAU, which we haven't even gotten to. The PAU certainly plays into readmission. The thing that I don't understand, and maybe this is part of Amy Boutwell's suggestion, is that if we front load too much, we may be setting ourselves up for disappointment because the rate of growth initially, reduction, was lower in the national level. And with all the factors that we're now putting in the mix, PAUs and the other pieces, plus the fact that we're behind in Oxford, Maryland, you're right, there's a huge range of how Oxford is in Maryland, that we might be better off not front loading the first year and then evaluating to see if we can escalate faster. We all want to get to the same target. But because of looking at the patterns of national, we may want to reconsider another scenario of slower change than the front loading.
Yeah, Diane is going to get to Amy's point, but I think she also agrees with you. The only consideration is that we did have, ARR, and it's not like we are starting from scratch. We did some groundwork already, but in general, I think we do agree that you can assume that the majority of the improvement is going to happen right from the gate. It takes time to build all those things.
Yeah, so my final point on this, and it goes with that as far as whether you're trying to be conservative or not. Again, going back to the math of it, I think that if you make the assumption of 5% in scenario 2, and you do it as a percent of a percent, you're really kind of tacking on like 2 hugely conservative numbers. In other words, scenario 2 is really heavily front-end loaded because it's setting a high national target, and just the way the math works, you're kind of bridging that gap by a good chunk. So.
Yeah, by the way, both of them are using percent per percent.
I know.
And I did do the percentage points, and I didn't see much difference between the two. So because of the way numbers working percentages. So the front loading wasn't intentional. So this is kind of the way that the percents are working when you translate them into a percentage point. So the other issue that we are going to be discussing mainly in the next meeting, but I want you to be aware of it, this is still a Medicare target. So we need to discuss whether for the payment policy, whether we need to translate that into an all-payer target, or whether there are ways for us to also ensure that the Medicare target is reached through some incentive. So the math, we are going to be looking at the ratio between all-payer and Medicare, and next meeting we can give you some scenarios about that relationship. But my experience from the per capita calculation is that regardless of what you do, there is tremendous variation in terms of growth rate or declining rate in this case between Medicare and all-payer. So we want to look at that relationship a little bit in more detail and come back to you in the next meeting about our assessment of how predictable it is if we just did an all-payer target and whether it will ensure that we're going to reach the Medicare target. So that's kind of the target and the measurement side of the thing. Then what do we do with it? If we agree on how we are going to measure it and our targets, and how would we translate that into hospital payment incentive and hospital measurement? And since we don't have a good risk adjustment and we don't have out-of-state information, it is not reasonable to do any kind of attainment, strict attainment scale using the readmission. And I think it will be most appropriate if we use an improvement style program for the readmission. Then the question is whether it's more reasonable to do for the first year. Again, this is just for the initial year, to have a uniform certain percent decline expected from all hospitals. So, for example, if the state target is 10%, would we expect all hospitals to go down by 10%? Or whether we would like to adjust that to the level of readmission rate that each hospital has. So in the tables, in the Excel tables that you have, So in table 1, this is an all-payer and 30-day all hospital readmission rate for fiscal year 2013. So this is our baseline readmission rate. And in terms of just columns, you see the unadjusted readmission percent is similar to what our CMS target is going to be with some adjustments. So it's 13.7% statewide. And then when you do exclude the planned admission, then the percent is 12.5%. So there's a slight decline as expected because we removed some of the planned admissions from it. And then here, we are showing you the two methods of risk adjustment. One is admission DRG, those two columns. And then the other one is the discharge DRG. And the last column is showing you the difference in rate between those two methods. In terms of segmentation, then it's important to look at the range of the readmission rate. So our highest readmission rate is at 18%, and our lowest readmission rate is at 8%. One is inner city hospital, you can quickly see, another is a rural hospital. So in terms of just thinking about what we could expect from hospitals, whether we should try to differentiate hospitals based on these readmission rates is kind of a question that we need to think about. And if you just turn the page, the other one is for Medicare rates. And here, in terms of statewide average, you see that the Medicare and unadjusted readmission rate is 19%. And you exclude the readmissions, it's 18%. And then you see the range from 18 to 8%. I would say don't pay attention to the rates. They should be higher than the all-payer rate. So I'm not sure. Sorry about that. Right. Unadjusted are higher. Anyway, I'll get back to you on the risk adjustment for Medicare. So you can look at the range on the unadjusted rate from 31% to 10%. And for people on the phone, but I'm trying to show
right, and they're not posted because they're for modeling purposes, and they have hospital-specific information and are not intended for hospital comparison.
So again, if other people are 3 steps ahead of me, I apologize, but the unadjusted column on the Medicare column, the 3164 down to the 1089 with a total of 1935, is that the number that we're in theory comparing to the national average of 1766?
Yes.
And do we have any concern, and I know the target is what the target is, it's fine, but is Maryland's overall demographic different than the national demographic, meaning we have more urban, which explains some of the difference between the readmission rates?
We, as the state, had that concern, and CMS did not. It's mainly because of the issues with the risk adjustment. There's a big debate, as you all know, in the policy world, whether you adjust for socioeconomic factors and other things. And CMS said, let's just start with simple calculations. And I think as we move through year 1 to 3, then we will have an opportunity to go back to them and explain some of those differences. Right now, we did look at the readmission rate a lot, but at the end of the day, I don't think nobody knows why we have such a high readmission rate.
But I don't think it's population-based, Justin. I think we constitute about a 50th of the Medicare budget. We're sort of a microcosm of the Medicare program in a state. And I think that, as Shule said, that it's not believable to think that our population is special, warranting a high, the highest, besides the District of Columbia readmission rate. There's something else.
You're saying our demographics are similar to the national average?
Yeah.
Huh?
David Mann has a comment on that.
Yeah, if you think about it in terms of racial ethnic distribution, our black population is about twice as a percentage, twice as large as the national black population. They have the biggest health disparity. So I'm not sure I would necessarily say we're demographically similar to the national average.
I agree with you, and also looking at the HCC scores, we are very slightly higher than the national average. But again, we are also in a high equalizer region. You know, we did have comparisons to the national average on the per capita basis, and we are in a eastern ward has high utilization, and there might be a link between high utilization and readmission rates too. But in terms of the CMS perspective, there wasn't any good explanation why we should be higher than the national average.
Well, obviously, I think we need improvement. I don't think that's in question, but maybe we should consider to keep looking at any demographic changes that might help explain the difference, because I'm just thinking, what if you don't get the reduction that you need? You might want to know some of the reasons why you didn't get there.
Well, the other issue is the more reasons there are, the more multidimensional the effort. And for instance, Shule, I think it was before your time that we did look at Dartmouth's Atlas information. I haven't heard that term in a long time. I don't know if it still exists. Yeah, it's data for us, but what it showed was that Maryland had higher utilization because people with health care was very available, and in the states where that was true, it was a challenge. But again, it's a different challenge than readmission. They may interplay, but it means it's a tougher challenge to get it down. I also just have the question, and again, this could be my own ignorance, but it seems that all payer would muddy the waters if we don't have a national statistic on the Medicare, right? I mean, I know we have all payer and we also have Medicare for Maryland, but we don't have all payer for national, do we? It's just Medicare. So wouldn't that piece also kind of muddy the waters at this point for us? Because we don't know if we could or should match what statistics for non-Medicare. Maybe I'm getting ahead of myself. I'm just not sure why bringing in non-Medicare would lend clarity at this point.
I think my point was, from our perspective as an all-payer state, all our policy programs have been all-payer, and hospitals have different distributions of the payer mix, obviously. So it's kind of, that's what I meant by looking at the all-payer readmission rate. Obviously, our target is on the Medicare side, and you're right, we don't have any all-payer readmission rate comparison at this point. So that's kind of the principal issue for our policy program, given that we have Medicare target. What can we do? Can we set the improvement rate solely on one payer information?
Yeah, I just want to make a general point about comparing Maryland to the nation. To the extent that that becomes an issue, and somehow people think that Maryland's performance should be able to match national performance in some great unstratified way, is probably a really mistaken interpretation from data. I'll give you the example that we end up confronting most, which is infant mortality. We're ranked like 42nd or so in the nation in infant mortality. But if you look at the black rate, Maryland matches the black rate nationally. If you look at the white rate in Maryland, it matches the white rate nationally. So group by group, we're not any worse, but we blend a 30-70 mix of bad and not so bad, and the nation blends a 15-85 mix, and that's why you get these differences. So if some of what's driving some of this and some of the expectations on the table, why can't your statewide rate match the national rate, and it's not adjusted for rate, because rate has got huge differences in frequency and severity of all these major conditions, we'll never catch up. So someone at some level, CMS level, state level, got to understand the importance of that rate adjustment.
Well, some would argue also about socioeconomic status as well. And I believe, I know someone will correct me if I'm wrong, that we are a relatively wealthy state. And we don't have an adjustment for that. But I think wealth and resource may also be impactful, but we can't adjust. But we can stratify by race. So good point.
I think it is a good point, because I remember reading that statistic as well as a state. However, for instance, Baltimore City, if you really look at the population, it's skewed by the average of the city. It's way, way, way below. It's the biggest concentration of population that's way below the national average in income. So it's certain counties that are lower in population that really use that statistic because they're so high, right?
Question for Delmarva. Have you done any race-related readmission analyses?
Yeah, so we've done disparity analyses. So what I do is national, so looking nationally, and we see for the measures they're concerned about in Medicare, at almost every measure except for COPD has disparities with African Americans, Native Americans doing work. In those measures, although not as bad as dual eligible, by far they need to be a target. So I was going to say we've also looked at rural urban, and so coming back to the utilization piece, we've seen that far fewer adverse outcomes among rural populations, even though they don't have access, the same access to hospitals. So we are thinking it is that, especially for adverse drug events and hospital-acquired infections, it's protected that we don't go to a hospital. So I mean, I don't need to be stuck about that. The worst outcomes are for sure in urban areas among the parties and dual eligible.
I was just going to mention I agree, and I've also done research that has shown the impact of disparity both in terms of higher use rates for dual eligibles and the non-white population, and the impact those things have on quality scores such as the NC2, the star ratings. I'd also, on the bright side, though, I'd also point out, did some research where we compared a plan that did heavy care coordination to Medicare fee-for-service, and didn't set out to find this, but we were pleased to see that once you applied the care coordination, we showed that it made substantial strides in increasing physician services, primary care services, reducing hospitalizations, and what we found was that it made much greater improvements to the non-white LIS population, and in the end, the endpoints were about the same. And so I think on the bright side, what it shows is that, under this new Maryland model, if we focus on where the problems are, where there is disparity, I think we can really prove something great compared to, we can show that you really can move that population along by being helpful and creating access.
Right, so the challenge is opportunity at the same time.
Yeah, but you're right. We don't want a score that says it doesn't give us credit for our starting point. It's fair to be, your starting point should be taken into account, but at the same time, that's an opportunity for us.
So then just one thing that I wanted to mention also is in terms of the targets. So we're going to discuss the segmented approach. The other issue that we need to keep in mind is, since this is a 5-year strategy and we are using an improvement method, we need to consider to make it cumulative. With that I mean, if you set the 10% target and next year, let's say we did 5%. For those hospitals who did more than 10% in the first year, obviously will have harder time to reach the second year target. So I think maybe we can have the principle and an understanding that for the future years, you need to think about that cumulative improvement rate rather than year by year for hospitals. Okay. So then I just wanted to give brief information about the planned admission definition. So we are using the CMS algorithm version 2.1 published on March 2013, and the specifications are available on the website. And this is basically using clinical classification codes for primary diagnoses and procedures. And certain diagnoses and procedures are considered 100% planned, including organ transplants, chemotherapy rehab, and in this version 2, they added vaginal and C-section delivery, which obviously they were focused on Medicare, and as this is becoming widely used for all payer targets, they added these two conditions. When we looked at it, we noticed though that the way the algorithm works only takes the normal deliveries and normal C-section, not like forceps and other things. There's like huge list of the ICD-9 codes. So we made a correction at HSCRC that we are using API-DRG for this exclusion for vaginal delivery and C-section regardless of the ICD-9 code, so that we consider 100% of these two cases as planned. And the next table, overall 23% of admissions are planned. Majority of them are delivery, obviously. And then the other ones, as you would expect, joint replacement, hip replacement, and also some other procedures. So basically, if we flag them as planned, they are not counted as readmissions, but they are still readmissions. Now we are going to move to some feedback from Amy Boutwell, and Diane is going to be her voice.
Yes, I'll try to zip through these quickly. Amy is a physician who's also an expert on working on the care transition through the country. Really, she works at the IHI on the state-led program to reduce readmission, state collaborative. So on the topic of setting targets, she agrees with our 1-year versus 5-year approach. There are a lot of pressures in the U.S. That will remain constant, but we are different in that, and then our incentives are different. So also, she believes there's some start and then plateau, and then maybe another wave of improvement with reducing readmissions nationally, and that work 16-17 to reduce in 2016-17 maybe to reduce readmissions maybe the result of the skilled nursing facility and home health focused work that CMS will focus on there. But still we may be different, and certainly because of our ability to create the incentive.
Can I just ask a clarification on that? And again, I want to make sure it's not just me not being grounded. And first of all, of course, I agree with setting the target to your time. But when we talk about our targets, are these matched to what we discussed last meeting about the incentives and risk financially every year, or are these part of just the overall goal for the 5 years? Do you understand what I mean by the difference? In other words, every year that we have a target, is that linked to the financial incentive or risk as part of that MHAC QBR equation, or is it just on the road to the goal?
Is it a measurement versus will it be linked?
Yeah, yeah.
I think the intent is to link it to payments.
That's what I thought, but I want to make sure we're all grounded in the same thought. So every year it's linked to the payment. For instance, if we are losing something about a risk opportunity percentage of saying 5% or 5.75, I don't know if it's been talked around. And we already know that 4% is MHAC TDR. So every year, whatever we're setting, we're linking to that difference, correct?
So on the next topic, Amy opined on the question of front-loading the target, and that there's a two-letter answer, no, and that readmission rates don't move quickly, points that have been made here. I think Barbara, you made the point earlier, 12 to 18 months for a ramp-up period was the various initiative. You have to have really transformative approach, and we believe, Commission, that means care delivery, care coordination, care transition initiatives paired with financial incentives. We believe that's the transformative equation to really make an impact. And then she talked about the shifting denominator. So the sort of not great news here is that our improvements in Maryland may be related to increasing Medicare beneficiary population and not truly a reduction in readmission. Is the upshot of her comments here.
Yeah, in the first meeting, we spent a lot of time in terms of the denominator question on the percent admission. What we heard from her is actually on the per 1,000 population measure, there is also an issue with the increasing beneficiary number that impacts that one. So my take-home message was that neither of these measures seem to be perfect. They both have the denominator issue, and then her comment is, if you're looking at the transitions, then probably it's better to use the admissions as a denominator rather than the population.
Her next set of points were, so she doesn't believe in risk adjustment or planned readmission adjustment. But that's because she's looking through a quality improvement lens. We are looking through a lining up incentives with program and care delivery implementation. So those are different questions. So we will recognize those differences here. And then, so again, no risk adjustment, and she specifically recommends against it for quality improvement purposes and tracking. And then she talks about this segmented approach where you recognize where a hospital is starting from. So if they have a very high readmission rate, you set their target more aggressively than you would for a hospital with a very low readmission rate. But even for the low ones, there are points where that you have to set something because all hospitals can improve. And the segments have concerns when you have cliff effects. So if someone's at 22 versus 21.9, then their percentage point expectation may be dropped by 10%, and is that fair? So we kind of have to work through that. And that's the end of the comments, the gist of the comments that Amy provided, where we were asking for input, and we were very appreciative of her input, and she would have been here if were the timings work out.
I think this is very helpful.
David?
Just curious if there was any empirical or model data that supported her conclusions, because I have to say, I'm just kind of, from general principles, I think I disagree with most of what she
Well,
so N of 1, I'm not sure is proved in this case.
Well, and she's worked with 5 states over 10 years only on readmission and care transition work. And she is, again, focusing through a global quality improvement lens, not a hospital-specific comparison lens. And Tom, would you?
Yeah, so in reflecting on Amy's work, Diane has done a nice job of sort of giving the context that Amy's work has been improvement as opposed to accountability, and I think that's really important here for the reasons that were raised. But the other thing is she's been working through the IHI programs with the early adopters, so to speak, the really serious, committed folks over 10 years. So from her perspective, and Rob and I were having a sidebar conversation about this, she's already seen tremendous progress in some of these organizations, and she's reflecting in some of her comments that some of the low-hanging fruit has already been plucked. Some of the opportunity has already been wrung out. But when you look at the national data, the numbers are just now starting to move under the Partnership for Patients campaign. So I think her comments are a little bit farther ahead of where we are here, and we need to back up a little bit and think about what it's going to take to really rev up the engine in Maryland to catch up with some of these organizations that she's been working with over 5 to 10 years. So we want to be careful that that we don't make assumptions that the Medicare rate isn't going to keep moving and at a potentially accelerating pace, as the Maryland rate needs to keep pace with that, and has some ground already to make up. But I don't think we should assume that the national rate is going to slow down.
David? My point is, she may be right about that. I'd like to see the underlying data that supports the conclusion. This is a slice of the conclusion. I'd like to see some of the empirical evidence that supports the result.
But they do have, I remember seeing a lot of reports on the citation stage where they track the readmission rate, and I believe after 18 months, they see the movement in the readmission rate for that point. And for the beneficiary denominator, I do know from the data I looked at, not particularly for the readmission, but our number of beneficiaries has been growing about 2%, and then I think it was 3 after that. And in the last year, we do have a 4% increase in the beneficiaries. So when she made that comment, I'm like, oh yeah, that makes sense to me, seeing just the beneficiary side of it. And I'm happy to send over. So we are going to come back again with some similar discussions in the next meeting, but by next meeting, we need to have a sense of where we are regarding all these discussions. So in terms of adjustments for plan, case mix, I think we have the policy improvement side and then the accountability perspective. I don't know if we have any consensus on that everybody agrees we should do those adjustments, or seeing our rate is not adjusted, maybe we are better off not to have an adjustment and we use the low rate for the program. With the thinking that it's going to be attached to a payment, but most likely thinking is to have a positive incentive, if that will be helpful. So I think the idea is we're going to pick the state targets, we're going to come up with some hospital targets for calendar year 14, and if they reach those targets or exceed, then there will be additional update factor, most likely, that will be provided those hospitals in fiscal year 15. I don't think it's reasonable to have a revenue neutral scaling in this case. As we all know, there are lots of issues with it. But we may need to think about for hospitals who are not performing at all or doing very, low job, and then what you do with those hospitals, we can also discuss in the next meeting in more detail. Any comments on risk adjustment and plans?
Just that, because little will happen between the two meetings, most likely, for us. I mean, you'll be doing what you do statistically, but if there's anything further to throw out for us to go back and do some thinking and conferring about, that would be helpful. For instance, some of the things that we talked about, not front loading and not including one payer or including one payer, if we have some idea of where they're headed, because it is 14 now, and we're several months, we will be several months in 14 by the time. That would be helpful. But the other question, and I don't even know if there's an answer, maybe it was done in a reading, does Medicare, do the other states have an idea of how low readmissions should be. Because right now they're working with their improvements, their comparisons, their benchmarks. Does anybody have an idea of what the endpoint should be?
Didn't they say, wasn't the Partnership for Patients goal 30% reduction?
In
3 years?
3 years.
Yeah.
And we could also bring you the state rankings. That might be helpful. We did look at that, kind of see where each state are and who they are. The data was last. I think Calgary or Falls is the most recent that they have, but maybe Partnership for Patients may give us more recent one on their MARVA. It might be helpful to see that distribution before the next meeting.
I think it would be, and also just to know if there is a proposal that you are already thinking of with the agency, simply because we've all now been talking about this for now, so it's fresh in mind. My fear is we have another meeting, but we've done it in between. And at what point will we already have recommendations? So we're going to be using the
I know the 2IO goal for the next 5-year contract is 20% reduction in readmission and prevention sensitive admissions over 5 years. So is that
it actually does.
I'm sorry, back for a question. That makes sense to me from a statewide perspective, but if you're setting payment targets at a hospital level, and we've had hospitals that have been working under ARR for several years, they've seen considerable reduction already. So I think Barbara asked a good question. You know, if you're already hovering around 14, 13%, how much lower can you reasonably go, knowing that it's going to be tied to payment? So I think it's a good question at a hospital-specific level, considering all of the, the patients that you serve, and not to throw out PPRs, but I'm kind of thinking, where is that floor, really? It's a good question.
I can tell you the numbers. I don't remember, but they weren't 14%. They are in single digits in terms of the floor discussion.
Like a hospital in Vermont, or, I mean, I think these have to be considered, right?
We'll think into some of that conversation. And Steve Jenks, I think, had some papers on that too, and you can check with Amy. But the discussions I remember were the around 5-6%, like in relation to the PPR discussion. That's really correct.
So the last issue is the little payment versus improvement issues that goes way back in everything we've ever talked about in terms of goals. And again, is it a flat reduction, or does it consider where hospitals are that have been working on readmission already? Because there is, according to your data, pretty wide disparity.
There's two things that I want to raise that are related to this. One is about the positive incentive. Will the payment work group have a chance to meet to talk about that before we meet again? What I'm concerned about is, I think where their heads may be is, where's that incentive coming? Where's that new money coming from? And I'm sure there's a general bias in that group towards they'd rather see an update that's at least around factor cost inflation, rather than give an update that's lower so that there's money to give a readmission kind of bonus.
Maybe that's the hospital perspective. So I heard also to have increasingly, like the potential avoidable information discussion that we've been having, to increasingly link those updates with the performance rather than giving the full factor inflation. But to your question, the timeline is by the end of the February, early March, this group would have some recommendations and input to the staff recommendation for readmission program, TPC program, and then we're going to take that in early March to the payment work group to think about the issues that you raised, whether they think that there should be an additional money through the update factor, or if there should be other ways of financing the program. I think the PPC program we said the issues there are more about the measurement. The readmission program that we need to work with payment work groups.
Yeah, I would. Okay. The other one is getting a little bit into the detail of the calculation of our readmission rate. And I know that we're pretty well set on using the Partnership for Patients definition. There's one little piece that concerns me, and you may have already worked this out, and that is nationally, when they calculate those readmissions, they can exclude psychiatric hospitals because they're paid under the psychiatric payment system, not the inpatient prospective payment system. In Maryland, excluding our couple of specialty psychiatric hospitals, the hospitals that have distinct psychiatric units in Maryland have the same provider number and are paid under the HSCRC system. So on a claim in the Medicare data, they look the same as the rest of the somatic acute care. So my concern is that in our calculation of readmissions, we have a disproportionate percentage of patients with primary psychiatric disorders. And while we want to be concerned about their readmission, we know that they tend to have a higher readmission risk. So I'm concerned that that skews our readmission rate a bit. And I don't know if we have a way in doing our calculation or maybe when the QIO does the calculation or CMS does the calculation for our waiver goal, did we need it or not, can that be excluded from the Maryland data?
You know, we've been talking about that issue for a while. We will be exploring that when we get the data and run the same algorithm and see what comes up with the national one. In terms of the Maryland rate, I think that's why we need the case mix adjustment at least to make that a little bit equal between the hospitals. But in terms of the national one, the one thing that we didn't know that they exclude zero-day readmissions from the calculation. So we were concerned with the transfers because we require hospitals to discharge the patient to be admitted again to any subunit. And the way algorithm works, regardless of the discharge code, it seems like they're excluding them as transfers. So that kind of took the pressure a little bit out, thinking that that may handle the issue with the subunit. But in terms of the case mix impact of it, I think that's something we should explore.
So does that mean, I want to make sure I understood, so by that algorithm excluding the transfer, say between the somatic part of the hospital and the psychiatric part of the hospital, that would get excluded when the person's transferred. But it wouldn't exclude someone being admitted to just the psychiatric unit.
Right.
Okay.
That's the part that we need to explore.
Gotcha. Okay.
Is rehab also an issue?
Yeah, I was going to ask the same question. Yeah, I thought I understood it, now I'm not so sure. I assume that if a hospital has a rehab hospital, a rehab floor, it's considered separate hospitals, still have the same number. But when the patient is discharged from acute care, say orthopedic, stroke, whatever, and then admitted to rehab appropriately, that would not be counted as a readmission.
If it is on the same day, it won't count in the algorithm.
Right.
If it is the next day or 5 days later, it will be counted as a readmission in the CMS target. I think my first strategy would be when we get the national data is run the planned algorithm at least to see if that has any impact with the national and the Maryland numbers, and that may take some of those rehab and we may have those chemos too. I think we can work on the national estimate through the next couple of months to understand better what adjustments we need for the national one. But at the same time, it is what it is right now. Even though we do the adjustments, I don't think we are going to have a tremendous impact on our readmission rate to get up to the national average. We may get some additional percentage points with those adjustments, but I think we will still have to do a lot to improve.
So Barbara and others, hopefully we recorded all of these points that we need to do in a recap, and then the things that we need to consider as we're constructing this draft recommendation, with the points of which will need to be articulated clearly in the 28th meeting at 1 to 3:30.
No, just to be sure on site, there were two issues. One is that transfer issue, but the other issue is just the documented much higher rate, almost double for most hospitals if you're spiking it at all. In other words, they are just going to be readmitted in the
Right. Okay. Oh, hi, Dan Wynn, are you on the phone and you have questions?
Right. So I just dialed in, so I have to apologize. I dialed in, people were talking about paper. They were talking about how they may exclude people with self-diagnosis. They do have a higher rate of readmission, that's true. That's the reason.
If you're on a speaker, and maybe just cutting in and out, because maybe. Okay.
Isn't that the reason to include them, not to exclude them? Just because they're more challenging, why would we exclude them?
The issue is that the algorithm that's used to calculate the Medicare rate, which is the one they will judge us whether we're meeting our target, that excludes psychiatric hospitals. So we disadvantaged at meeting our statewide target, which is that in 5 years we need to be at the national Medicare average for readmission. So we want, for those purposes, we want to count those patients appropriately.
Okay, so could we exclude them from that and include them in some other way?
And I think that might be an alternative for the payment policy if we do risk adjustment and expect hospital performance that adjusts for that. And that's exactly, I think, where the conversation is.
Okay, thank you.
Thank you.
All right.
Okay.
All right, so we'll continue with the readmission in the next meeting, and I will also create more scenarios with different specifications for you to look at before the meeting.
The next speaker we have is not HFPRC. It's Tracy Boutwell. And do you want me to push the button, or you want to come up here?
I can go up there.
Okay. Is going to talk about we the commission has been briefed about some ideas on redesigning the Maryland Hospital Acquired Conditions program, and Tracy will discuss those ideas.
And while she's settling in, Dr. Albert Wu from Hopkins also joined us on the phone, so we welcome him.
So we've had a work group who's been working on redesigning the incentives within the NHAC program. And what I'm going to present to you today is supported by MHA. We've had a lot of quality folks look at it. We've had a lot of finance folks, and they like the direction. So we wanted to share those with you. What I'll talk about will cover a couple of different things. First of all, the background, why we would want to change the existing policies, what our guiding principles were in developing these recommendations, and also a little bit about the timing, which you might already know, but I think it's good to put it in there. And then our recommendations, I'll split them into measuring, like how do you measure, how do we think we should measure complications and hospital performance. And then I put in just a bit of the payment part, even though we're not the payment group. I think it's helpful just for completeness.
And then I have one little slide with a couple of issues that remain to be addressed. So the background. Why change the existing policy? We know that in the waiver target, we're going to use 3M, potentially preventable complication software. We have the 30% goal, and that's on all 65 PPCs. So the software that 3M has developed defines 65 PPCs, and this methodology will include all of them. We do have a targeted list of 20 PPCs, and we developed that by looking at PPCs that were high volume, high cost, and a lot of opportunity for improvement. Plus, we then added PPCs that map to complications that are focused on nationally. And then we also know that the, as we mentioned earlier today, the revenue at risk under Maryland policy, quality policies in the aggregate should be commensurate with CMS policies and their revenue at risk. And I guess I'll just mention there, we purposely use the word commensurate, not equal to, because it's a strong feeling that in the CMS policies, they have 5.75% of their Medicare revenue at risk for fiscal year 16, and we're talking about 5.75. If we do that on an all-payer basis, that's a huge amount and much more risk compared to national, who just have that amount of risk for their Medicare. We disagree about that, I think, but
I think the contract says equal, but if we need to
so our guiding principles, the first one and the most important one is that we thought that this policy should help us to meet that 30% goal in total and make good progress annually. And again, to focus on the areas where we have the greatest opportunity, and also as best we can to match the goal, the metric in the policy with the goal for the waiver. And I think for MHAC, that's much easier to do than it may be with our readmission discussion that we've been having. We like predetermined performance targets and financial impact. So what that means is to say we set a goal and a target, and if you hit this particular target, this will be the financial impact. If you miss it by this much, this will be the financial impact. So that hospitals can know as they're going through the year how they're performing and where they are relative to those financial impacts. We also thought that if you structure the incentives in a particular way, that will encourage cooperation and sharing of best practices among hospitals. When we look at the MHAC rate, the rates of PPCs among hospitals on particular PPCs, there's a good amount of variation there. And what that tells us is that some hospitals have figured out some good approaches to particular PPCs, and we'd like to leverage that. Hold harmless for lack of improvement is attainment is highly favorable, and that really comes into play because we've been at this for about 4 years, and some hospitals have improved a good bit more than others. And we wanted it to be easy to measure as we go along. So the timing, just to refresh our memories, for the waiver goal, calendar 13 is the base period. The measurement period began January 2014, and we're looking at the 30% cumulative reduction by 2018. For the recommendations for this payment policy, we like the base period to be FY 2013, and that 6-month difference gives time to calculate threshold benchmarks, expected values, so that those are ready to go right at the beginning of the year.
Which is the existing policy, so there's nothing from that.
Yeah, and we like that. So the components of the redesign. For the measurement aspect, again, as I was saying, we would look at all 65 PPCs. The current policy looks at 50, and this is not a criticism of the current policy. That 50 was a good what was good at the time. Also selecting PPCs for focus, We'll talk about how we design and calculate this MHAC score. We'll talk a little bit about thresholds and benchmarks. For those of you who are familiar with the National Value-Based Purchasing Program, we use thresholds and benchmarks, and the hospital gets the better of their attainment or improvement score. And we use that in the Maryland Quality-Based Reimbursement Program. This was the 4 measures and other things. And then the payment methodology really is just, once you have that individual hospital score, how do you translate that to the payment impact? So we thought about different ways of counting impact. If you look at just the total number of hospital-acquired conditions, it's neither risk-adjusted nor volume-adjusted. So while that's the easiest thing to count, it's maybe not a good way to compare one hospital to another. You could use an unadjusted MHAC rate, which does adjust for the volume, but it doesn't risk adjust. So where we settled was risk-adjusted and volume-adjusted using an observed to expected ratio. And just as a reminder that when you're looking at observed to expected ratios, you want that number, the lower the number is, the better. So again, the targeted list of 20 PPCs, those were, what we did was we sorted the PPCs by volume and by cost. And we have some examples. So there's an example on the next slide of how that looks on an all-payer basis and looking just at Medicare. So when we did cost, we Julie knows this calculation very well, where in past years there's been a regression to kind of determine what the additional resource use is when a case has a complication. So that's what we call the cost. So we looked at that cost plus the volume, multiplied those, and that was the total PPC weighted impact. And we just sorted by that weighted impact. And the top 10 lists for all payer and for Medicare are very much the same. There's a couple that are in slightly different orders, but the PPCs on the list are virtually the same. So we went with that list, and then this slide shows you how we added in the CMS hospital-acquired conditions. And then there were a couple others that just seemed to fit. They were like a pair. So that's how we got to our top 20 list. Then we said, okay, we got the top 20 list. Those are the PPCs we want to focus on. How do we bring in the remaining PPCs? So we said there are some where clinicians had concerns about the PPCs, and we didn't think that those should be weighted as heavily as the top 20. So we said, let's put those in a bottom tier. And then we said, but there are other PPCs that may be common among the Medicare population and that are common among all hospitals. So it was those that were common among the Medicare patients and among hospitals that we put into Tier D. So then what we had is we said, let's weight those. So when you calculate a score, which will come a little bit later, we have the highest weight, 100% weight on the PPCs in Tier A. Tier B, we weighted those at 60%, and then in Tier C, weighted those at 40%. And you can see this is the distribution so there's, of how those PPCs fell out. And it turns out that it's fairly evenly split between the opportunity for the PPCs in Tier A and the combination of the rest of the PPCs in Tier C and C. There they all are. You can't see. But if you want to, if those are all of the PPCs in which tier they're in, I did bring hard copies if you want to see those. I'll put it back. So more about the measurement methodology. And as I was saying, in the quality-based reimbursement methodology that we use now and the National Value-Based Purchasing Program, each measure gets scored for attainment and for improvement compared to the prior year. And the hospital gets, whichever score is higher, their attainment score or their improvement score, they get that score. And that effectively, for hospitals who have already done a lot to improve, it gives them credit for that attainment. But it also gives hospitals that are working hard to improve but haven't made it to that high end yet, it also gives them recognition. So the threshold and benchmark, this is how we do that. The threshold is the minimum performance at which a hospital needs to perform to begin to score points. And we've set that kind of right in the middle, and we'll get into that a little bit more in detail because there's a couple of options there. But for right now, we think of it as mid-range performance. And then there's the benchmark, which conceptually the benchmark is the point at which very high-performing hospitals are at. And that the benchmark is the point where you score the maximum number of points. So if you're below the threshold, you get 0 points. If you're at the benchmark, you get 10 points. If you're in between the threshold and benchmark, you get between 0 and 10. In setting the threshold, there's 2 options there. One is to set that threshold at the median of all hospitals. So you stack up every hospital in a line and say who's the hospital in the middle, what was their observed to expected ratio, and that becomes the threshold. And the thought process behind that is that, or the assumption behind that is that the case mix should adjust adequately for all the factors that affect the hospital's performance. Another alternative, and the one that we prefer, is to set that threshold as the weighted mean of all the observed and expected ratios. And what that puts that threshold at an observed to expected ratio of 1, using a base year of the prior year. So conceptually, what happens there is that the mean performance is measured more at the case level because it's weighted by cases. Whereas in the prior one, the mean performance is at the hospital level. Using the weighted mean inherently includes other factors that might affect performance besides just case mix. It also means that hospitals with higher volumes have more influence on those PTC means. So this, that's just I think to look at these histograms help to show you better visually the thresholds and benchmarks and the difference between setting a threshold at the mean and setting it at the weighted mean. So just to orient you to what we're looking at, on the left side axis, those are observed to expected ratios. So again, the higher the observed to expected ratio, the worse performance that is. You want to lower observed to expected ratio. So the smaller bars are better scores. The shading of the bars represents the revenue size of the hospital. So darker bars, bigger revenue. So that kind of gives you an indication of what size hospitals we're looking at. And then the other thing to look at, let's start with the threshold. So if you look at where that yellow arrow is, that yellow arrow is the median performance. So that would be setting the threshold at the median performance at the hospital level. If you then say what's the weighted mean, that's the threshold that's the straight line where it says threshold at 1. So that's how the threshold would look using the weighted mean.
And then benchmark towards the other end, you see where we set the benchmark is at the median of the top quartile. So you look at the top quarter number of hospitals and who's in the middle and what's their observed to expected ratio. That's how that works. Under our QBR program, we use the top decile, and we tried that for this program, and it set those benchmarks really, really high. A lot of them were near 0. And we felt that that wasn't appropriate because these are potentially preventable conditions where you wouldn't always expect a 0. There's some kinds of complications that are more like never events, and you might expect a 0 there, but not necessarily so for all of the PPs. So that's how we came up with top quartile felt better for a benchmark. And honestly, figuring out where exactly top performance is something that we don't really know. We don't think we're there yet, but we don't know exactly how low some of these complication rates can go.
In the top quartile region, it's also weighted by the admission, or is it the median of the weight of the hospital?
I believe it's the, if you want to help me with that, I didn't hear the question.
Weighted mean? It's
a weighted mean, yeah.
Like
for the benchmark too? Yeah, okay. So that shows you one. Here's another one to look at. Same orientation. This is a different PPC. This one is renal failure. The other one is shock. Just to have a look at how the thresholds and benchmarks shift with different options. I put this slide in there because it kind of gives you a visual of how the hospital gets a score. This is a scoring attainment. The threshold set at 0, benchmark set where the 10 is, and the number of hospital man set their score. Okay, so that's the main part of the measurement. The payment method that we're looking at is, so what do you do in this? Once you add up every hospital attainment and improvement and they're better of, and you do the weighting, the 100%, 60%, 30%, each hospital comes up with a score between 0 and 1. So how do you then translate that score between 0 and 1 to some payment impact? And that's where we have a couple of things today. And one is we're proposing 3% revenue at risk. And again, back to my comment earlier on the Medicare revenue. You know, we're supposed to add up to 5.75. We've got 1% at risk for quality-based reimbursement. This would put that total up to 4, leaving like 1.75 for readmission. But again, we think that that should be on Medicare revenue rather than all payer basis. But I know that's not for us to talk about.
I just want to make a comment. We never meant that it's not for you to discuss. I think just the recognition that we are going to take your comments and put it in the payment work group. Obviously, these are very interrelated questions, and when you're thinking about the measurement, obviously, you also have to think about how it's going to be applied eventually. But I don't think we can separate them easily in terms of just workload. The jurisdiction of final decisions are going to come from payment work group, but we're going to take your input to them, and then we'll bring their input to you.
So then the second point about the individual hospital impact should depend on a combination of the statewide aggregate performance and the individual hospital performance. And this is the part about promoting cooperation. So what we're saying is that if the CMS waiver goal is 30% over 5 years, which translates into just under 7% a year, we're saying that if we meet that CMS waiver goal, then the maximum possible penalty should be discounted, and we're saying to 1%. If we don't hit that CMS target of 6.89, then we're operating under the 3% maximum possible penalty. So how that looks is here.
And that is, the top one is, let's say we meet that 6.89%, and we're expecting to meet that 6.89%. Then if a hospital scores between 0 and 0.2, a hospital would have a 1% penalty. Hospital scores between 0.21 and 0.4, a 0.5% penalty, and so on. And this scale allows for up to a 0.5% reward funding that would come from any penalties collected. So if there weren't enough, let's just say that we did, every single hospital did really, really super on this in the first year, and everybody scored at a 0.8, which would be great. We'd be real close to meeting that 3% in the first year. But they would all be eligible for the reward, but if nobody got a penalty, then there is no penalty to fund that reward. It would just be what it was. So in the second scenario, this is if as a state we don't meet that 6.89 target, then we're facing much more onerous penalties. So again, this is a strong incentive for hospitals to work together, share best practices. So a similar kind of graduated performance related to seeing the impact there. And then these are a couple of issues that I think are still to be addressed. There's about 7 small hospitals that have very small volumes in a lot of these PPCs, so their expected values can be very small. It can be less than 1. So those hospitals in the PPCs, and nearly all of the PPCs, they tend to score either a 0 or a 10. As you can imagine, if a hospital has an expected value of 0.5 and they get 1 PPC, then their observed to expected is a 2, and that puts them way at the top. They're getting 0. If the hospital has a 0, then their observed to expected ratio looks really good, and they're probably getting a 10. So we've had some discussions about what we could do with them, but I think that's hasn't been fully fleshed out. The second area is ongoing discussions with 3M to refine the PPC logic. There are a few PPCs where I know the clinicians still aren't comfortable with how that internal logic works, and would like some adjustments there. And we've sent a bunch of information to 3M. And I know in the past they've considered that, just like they've considered changes to the AQR group, or they don't have to fit in with their timing, but just wanted to mention that.
And in the past, it didn't even fit with their timing, which happened in October, the revision, when we had some major issues with the previous options we had, and I think with one of the other PPCs, we made those adjustments in our program so that it happened before December, and that way we adjusted the expected for the performance. So that's always a possibility for us to do those kinds of adjustments if we catch them before the performance year starts.
And then the last one I mentioned a bit before is we really don't have a good handle on how to define exactly what is the very best performance that we could expect.
Can I ask 2 questions? The first question relates to the use of the 65 PPCs as opposed to 50. I remember correctly that the use of 50 was based on small cell size issues, and also how significant the statistics is for those 15 that were left out. So did you take that into account before you said the 65?
Yeah, we did, and that was it was something that we were concerned about and debated, because we did think it was we had some concerns about bringing all of those PPCs back in, where we landed was back to this kind of guiding principle of we wanted our metric to be measuring very closely what we were measuring under the waiver test.
So a couple of the, for example, for those who aren't familiar, an example was some of those PTCs were in obstetric complications. And we know that's not a Medicare thing, not generally.
There are
but the waiver test, since it's all payer, for Medicare, in our waiver test, it's all, we didn't want to just leave those completely out. So that's why we went with the 40% rating. Whether 40% exactly is the right number, it might not be. But that's what we thought about, and that's why we did it that way.
The reason why I asked that question is when you go back to the second to the last slide, and you are talking about the issues, and you are talking about hospitals specific value being less than 1.
Yeah.
That is probably one of the reasons, because you are picking PTCs that have, from the beginning onset, have low, small cell sizes, and are not really statistically significant.
Mm-hmm.
If I may, just in terms of differentiating the old and the new, the statistical significance, the old methodology really focused on additional resource use. So at the end, the scale was based on excess resource use if you had more than expected PTC. And this one is really dealing with that resource use issue with different weight, but not at a fine-tune level where we have the weight for each PTC, and making it more a general grouping of high cost and the highly rated, and then the medium, which is high prevalence, and then the rest. And the cell size issue, it could be related to PTCs, but it's mostly related to the small hospital issue. It's not, I think it's like some hospitals have any of those PTCs more than enough.
And that leads me to my second question about the tiers. Are there distributional effects on the tiers? By that I mean, do you have an ordinate number of hospitals in the first tier that are large hospitals with specific services that are prone to being in that group than others?
That's a really good question. And that was something, in looking at those, we wanted to be really sure that when we were, I don't happen to have it exactly on this slide, but when we were looking at what are those top 20, top volume and top cost, and by opportunity, we meant which of those PTCs had to be in a large number of hospitals. We didn't want to put a lot of PTCs in that would only be in certain hospitals. Now, saying that, there is, I believe that we do have some maybe cardiac PTCs that are in that top tier that don't apply to all hospitals. But for the most part, we really did try to get ones that had that were across all hospitals. Yeah.
Just to expand a bit on the expected value is less than 1, another issue I see all the time in my work is just looking at racial ethnic subgroups in small jurisdictions with event size within a year of 1, 0, or 2. And what that does, what I've learned is that we have a metric that we think represents some health concept, like say infant mortality or PPC. And if I look at American Indians with mortality, I can have 0, 1 year, 1 or 2, and up and down. The actual concept is kind of illustrated by a multi-point trend line that averages that weight, that population out over time. But any one point is not at all representative of the concept that I'm trying to measure. So there's this problem in small n's of decoupling the metric we have from the actual concept we think the metric represents. So I think that's going to be important to consider in the global discussion of this stuff when we get to small n's and things are going to be up 1 year and down the next. And for the PPC issue, I think one of those implications if you don't have some pooling mechanism to stabilize that might be the amount of money that can be at risk when things fluctuate a lot will have to be less, because otherwise the impact on an annual budget could be extreme.
And that might be particularly, if I'm interpreting your comments right, that sounds like it may be particularly relevant to those small hospitals.
Following up on that, can you comment on the advantages of having specific PPC targets versus pooling all newly defined and creating one threshold and benchmark?
Yeah, that's another good question. We started doing this work really last fall, and one of the first things we did was start looking at trends in PPC rates over time and by hospital. And what we found is that those PPC trends, the improvement trends, were very different by PPC. Some had reduced by like 38, 40%, others more like 10, 12, and then there were a couple that stayed kind of flat. So I think it was twofold, really. It was one from a hospital ease of measurement and knowing where to focus point of view. We wanted to say, let's break every PPC out. So if I'm a hospital and I'm not pleased with my score and I want to do better, I can look by PPC and see where do I need to go. And it might be slightly different for one hospital compared to another. So it's more broken out, but I think in the to assist the operations of the year.
I noticed in terms of state targets, we discussed the onboarding issue in the readmission one. I wonder, for the CPC world, what will be the appropriate thing to do? Yes, we do have 7% targets linearly. If you look at the improvement rate in the last year, it was 17%. And like the improvement is accelerating, basically. So what is your take on the onboarding issue with the targets?
I think that question really goes to the question of, are we looking at a quality improvement target or are we looking at a payment target? And I think given what our history has been improving on MPAC, that makes us feel that we can hit that 6.89 target. So we feel pretty good about that. Good thing it's there. We do need to keep our eye on that ball. If this was just for quality improvement, we would probably set that target higher. But since we're tying it to payment, we didn't want to put in another bar for us to meet. Since we've got the financial targets, there's several different financial targets. We've got the readmission target that's Medicare. We may be looking at an all-payer readmission target or one that might include observation. So we didn't want to put another target in there, kind of an I don't know if artificial is the right word, but a quality improvement target. That was the thinking behind that.
To me, I agree with you on principle, but it's like looking at that trend. I don't remember the first year, 9%, 10%, 17%, and then having the target at 7% is half of, less than half of what we all achieved in the last year. With the new waiver, I think the expectation is to be more aggressive, to do more things, and setting a target that was less than half of last year, I don't know, is giving the same message as we are committed to this and getting, you know. And
there's no disincentive. I think one of the points that I would make in that, though, is there's no disincentive to outperform the target. In other words, that methodology that she just went through still very much incents hospitals to improve greater than the target. So just because you're seeing past performance higher doesn't mean that, you know, the hospitals are going to get to 7% and stop. The incentive is still to throw as much as you can in improvement. So I think that's what Tracy's getting at, the difference between a quality improvement goal versus a payment goal. There's no disincentive to keep driving forward as fast as you can.
I do agree with that. And then the quality component to that discussion is honestly, it does get progressively harder as we move forward. First you learn about the virtual acceptance and admission, then hospitals learn to do better, and then it was documentation. And then I would say most hospitals really delved into the team-related low-quality improvement projects that cost automation, time, money, people. And I really think that's been one of the successes in Maryland, that we really delved into the BBB impact in Maryland. But it does get progressively harder as you get further and further into your goal.
Yeah, I guess we'll know when we reach that point until after the fact, looking into data. I don't think we can really predict when we're going to reach that point.
Probably that's correct, but I think what it does indicate, just like any that expression, the low-hanging fruit versus high dribble, it does take more work, and it's not that you're predicting it's going to go slower, but it just did. So I wouldn't want to temporarily make that goal greater at that very time, because we do want the quality to improve.
And even when that occurs, it will be a challenge then to sustain that, so that these quality improvement efforts, as you look and see where your performance is on one or more TPCs, and then you sort of think, oh, maybe I've licked that, and you move on to others, but then you see over the course of time, you still have to keep your eye on things, because this concept of I've licked it, we've learned isn't really the case. And so while you're expanding to look at additional areas, it is still a challenge to keep your eye on those areas where you've already improved, to maintain and even try to improve that even further beyond what you've achieved. So I think it just becomes increasingly, it sort of expands out each year as you try to hold on to the gains you've achieved in some and then get new gains in other TPC areas.
That's a great point. Just looking at two of the probably lesser TPCs that's still impacting, one is UTI and one is CARDI, that most hospitals learn early on about UTI and PLA from nursing homes, for instance. But you take your eye off the ball for 1 minute and it goes back up.
I guess there's one potential unintended consequence that strikes me with this, which is the benchmark, the median, and the average of the top group seems to be moving with time, if I'm understanding this right. So if you're under the threshold and you're trying to reach the threshold, and the threshold keeps running away from you, you may potentially have significant improvements in your PPC. But if you're not improving faster than everybody else, you never catch up, and you keep getting things over and over and over again. Does this create a system where the rich get richer, and we start to actually broaden the gap across the kind of the beginning, and that gets better, if you will, gets bigger? So I think is there a need to have something that says we're going to not only reward your relative position in the performance spectrum, but we also have a mechanism that rewards your absolute improvements compared to yourself over time?
I think this approach does that, because you look at the attainment. First of all, the benchmarks are fixed for 1 year, so theoretically everybody has that potential to get this sample. Theoretically. But then the scores are two. One is attainment, where you are vis-a-vis the rate, and the other is improvement. And the higher you do, that's the point you get. So I think the principle that they laid out, don't penalize us for lack of improvement if we are already at the threshold, would be taken care of with the scoring system. But then I think as the state moves further and further, you need to update those thresholds and benchmarks for continuous improvement until when we think that we reach that, the point. But seeing that rate, if you look at the quarterly rates too, they are still going up and up, and I'm under the expectation it is a bell-shaped curve, not a cliff that suddenly from, very 17% decline, we're going to go. I hope not. I don't expect the things happening that. It takes us to do those improvements, and from the policy, I think you can comment on whether you think they are sustainable or not, with the caveats for some PPCs. But in general, my understanding is there should be a bell curve rather than a growth effect that we suddenly lose momentum.
Does that mean, I think, I agree with you, and does that mean, I think what you're saying, if I heard right, as we continue to improve, at some point we'll see that threshold and benchmark sort of leveling off, and that's kind of, we'll know.
Right, I mean, if the decline in improvement right now is set to 17%, and if you have that threshold weighted, right, your one, the average is going to be 17% less than the previous year. And as we decline, those benchmarks are also not going to move as fast. So I think that kind of pendulum inside that you don't have to do, you don't have to concern too much.
And Tracy, isn't the short answer to this question too on page 8 where it says better attainment or improvement score? I mean, isn't that kind of what you're getting at?
As long as you don't have some threshold that you have to meet before leaving, that's what I thought I was seeing from the slide. Maybe this is the weight of the median threshold.
Yeah, that's true. I mean, if you're, let's say, just looking at this shop, let's say we were using that threshold of 1, and then every hospital that's on that side of it, if this was the only TTC we were using, then all of those hospitals would be getting 0. Unattainment, that's true. So they would all be getting a 0. But there is, if they improve significantly, and I should have included, there's a little formula for their improvement. I didn't include that. But they could look different on the improvement.
And you can get an improvement bonus or some credit, even if you're not at the 1 on the threshold.
That's
yeah.
Okay.
Yeah.
It's not, yeah.
Tracy, going back to page 22 on the translating scores to payment impact.
Yeah, that's just the thing that I was thinking of. Yeah, that's right.
I know you laid it out this way. Aren't you worried about some cliff effect on this?
That does happen. So the cliff effect is, let's say I'm a hospital and I've scored a 0.2, say a 0.19. I'm getting that 1% penalty. Whereas if I have my hospital next door scored a 0.22, they're only getting a 0.5% penalty, and it seems not fair. I could be the difference in their payment impact is not commensurate with the difference in their performance. True. You could stretch that out, but I think we're not that concerned about it because you can be tracking that throughout the year. And if you're in the 4th quarter, you know, all along the year, you're seeing your performance, you're tracking that. If you know that you're kind of on the bubble, you are going to bust butt. Sorry. to get over that cliff and to get on the right side of that cliff. It's not the right side. So that's why we're not as concerned about it.
Yeah, I think that it's equally applicable to the readmission. We are thinking about the segmented layer targets.
It may be, depending, I think the one thing is, depends on, what was really important in that discussion amongst the hospitals was how easily they felt it was to know their performance during the year and how easily they felt it was to control their performance.
Well, you know why I brought it up is that, you know, there's a tendency for individual hospitals to come in and say, look, we found out that our data was wrong. That's why we are on this, you know, as opposed to being here. So if we could submit our data, taking a 5% hit and submitting the data and getting the penalty, they weigh the option and say, okay, I get less money if I take, you know, the penalty in terms of submission of wrong data as opposed to taking a 5% hit.
Yeah. I mean, I guess that call is always up to you. If this is baseline case data, do every quarter. we've been submitting it for a while. I think hospitals are used to how you have to submit and code that.
Yeah, as a general rule, I think there is an understanding that we do not reopen the final data, especially for PPC and health-related issues. In our understanding, and this program has been implemented for quite some time, and we expect hospitals to catch those things during the preliminary, and it's basically too late for you to submit the final data and then get the rankings and say, oh, why are we at the top, and do digging and coming back to us a month later saying issues with the data. And I think in general, we only stated that clearly in the past, and we didn't open the data for that.
I think to the last thought I had is that we probably want to see if there's a way we can use our data to assure ourselves that whatever system we build doesn't somehow feel like hospitals that have a larger proportion of Blacks or African Americans in their case mix than other kinds of populations who maybe have less severity of illness or less high utilization rates, et cetera. It may well be that that's not the case, and maybe there isn't a problem. I think I remember some data where maybe it was this analysis that we looked at it by race and ethnicity really wasn't that different globally. Now, individual hospitals somewhere on this side of the palette, somewhere on that side, but the curve was kind of even over, no difference. I think we may want to make sure we kind of keep an eye on that to be sure that we're not creating something that somehow is systematically taking reimbursement away from hospitals that are high minority serving populations compared to the average.
I'm going to be controversial here. I can see with the readmission discussion to look at beyond case mix, but for PPCs that are happening inside the walls, to risk adjusting, you're accepting those differences as legitimate. And to me, I think we need to be kind of thinking about that side of it. Yes, I agree we need to make things equal, but at the same time, if you do those adjustments, what you're telling, in a sense, is it's okay to have this differential rate in complications because of your things other than your clinical factors.
Right, and I tend to agree with that in general. I think I'd like to look empirically at whether these rates seem to be different between particularly white and black, because if there's a component of complication rates that isn't a function of hospital practice day to day, but becomes a function of a differential severity of illness in the two populations, then if we see a systematic difference, we may have to change our mind and say there's some way we need to account for that, because I don't want to see a systematic revenue drain out of the hospitals that probably need more revenue than most.
I mean, again, we looked at data, there is a difference. The question is why there is a difference, and it will be hard to look at the reason and say, oh, it's because they are more severely. It could be some other issues that hospitals need to work on. So I think that's, to me, more of a conceptual discussion than an empirical work.
And a little bit that we looked at is all populations do worse in hospitals that are minority populations. To suggest that the quality is bad across the board. So in other words, you don't want to give them a pass.
Right, but on the other hand, they're definitely the hospitals who need to improve it, and I'm not sure that taking their money away is going to help them do that.
I think that's separate.
Well, I think we could float that to the payment group to consider, but I do think it might be worth measuring, if for no other reason, even if we don't want to make an adjustment for it. I get back to some of the points that were raised earlier. This is kind of the performance measurement group, and even if we need that data in future conversations with CMS, I think it might be worth running to see if there are differences. So ideas like that, I think we should keep on the table and look at it if it's possible.
I wouldn't be surprised if within a hospital it's not much different. I wouldn't be surprised if across the state you see a difference, and the difference was because the black population is being more in a poor quality hospital. That quality is bad for everybody. So you have to really kind of almost do a factor analysis kind of, or factorial design kind of analysis to sort it out. But I just think that if it's one thing that you have the incentive that they're going to pay you less money, but is that kind of defeating our goal because now they have fewer resources to try to fix the problem? So I just think we have to be more conscious of that potential issue.
Yeah, and that concept has been discussed before at MHA and other venues, but I think that's more for the other work groups.
Question from Daniel Rain. Please repeat how the risk adjuster will be.
You're unmuted if you would actually like to ask your question, because I'm not sure if we've gotten in the right context. He is unmuted.
Were you talking about risk adjustment?
Yes.
So I think you start off talking a little bit about risk adjustment, but at the end of the day, how good is it? Severity of illness adjustment?
Well, I think in what we're proposing, we're saying that we would case adjust based on severity of illness, case mix severity of illness, and leave it at that. And from a methodology point of view, we talked a little bit about adjusting for other factors, socioeconomic status, other things. We didn't have as rich of a conversation as we just had. That was a good conversation, but one of the things that led us to just stick with the case mix adjustment in these recommendations was that it was straightforward, and it was something that we're used to looking at, and that the more adjusters we would put in, the more complicated it gets to get your expected value and count where you are relative to that. So for that practical reason, that was all we adjusted for. Whether that adjusts for everything that you should, if it gets into this conversation that we just had, it probably doesn't account for all the differences, but we're not saying an opinion on whether those other factors should be adjusted for. But from a methodology point of view, to keep it more simple and straightforward, that was all we adjusted for with case mix.
Are there any states that are doing anything differently?
I believe not. So the ones who are using PPTs, this is a methodology that we work with 3M, and I believe they are using a similar methodology in other states.
The reason I just wanted to clarify is I expect we'll get a lot of questions from physicians about that, and it'd be good to know, if we say no other state is doing anything more sophisticated, it'd be good to know that that's actually true.
Is it fair to say that in other states they might be using on a more segmented population, like a Medicaid population, so it may be less important because just using it for a Medicaid population might inherently adjust?
And why don't we do that?
But they're an old-payer state.
Okay.
So we can do it. And
we don't know, but we don't know which members have Medicaid?
No, we do. In terms of an old-payer stage, we look at our measurements on an old-payer
Of course. But if one hospital has more Medicaid, are you saying those are inherently have higher severity of illness? And couldn't we adjust for that?
No, they may have higher resource use, but I think the API-DRG and severity of illness has been shown to be adequately adjusted for the patient mix.
Okay, so you're saying states that are adjusting for Medicaid are doing it?
No, states who are using the methodology are using only for their Medicaid population because Medicaid takes this and then implements this program. I don't know, maybe some private insurance companies might be using that. We don't know that knowledge.
Okay, I'm going to get back to my main question is, I'd like to know for sure that no other states are doing anything that's more meaningful and doable.
We'll get back to you on that with the confirmation, but with our conversations with 3M, Maryland has been on the forefront of the use of these products and methodologies in general. But we'll get back to you on that. Maybe some states catch up to us. All right. So thank you, Tracy. So the next step on this is for you to think about these differences, and then I think in the next meeting, staff is going to prepare a proposal that we will take into the commission meeting. And in general, we are in agreement with the general concept of moving the methodology to a score-based system. So the meeting date is that the question?
Yes.
The next one is on the 28th? One from 1 to 3? 3:30 and 2?
No, it's a CRC.
So we're going to go to our conference. So in the, we have,
Yeah.
all right, maybe in the next meeting we're going to start with the potential avoidable utilization. So we can give the credit to it. So what we did again is kind of the recap. One of the recap questions that we had was for you to think about the definition of potentially avoidable utilization / unplanned care. Are there any comments on the definition at this point? All right. And as we described, up to date, we've been looking at readmissions and including the revisit to ED and observation in the measurement, and looking at the PQI, the ARC prevention quality indicator, and the cost of PPCs. So here is, if we are moving to the rate on the NHAT program, this might be the avenue still to get a control of the cost side of it, because the utility of the potential avoidable utilization is more towards the per capita expense cost control reduction. So I think that's why in the agenda we put it as per capita cost control. So we think that the way to reach those targets, especially for Medicare, is through reduction of the utilization concept. And then the consideration, so that if you add the PPC cost, readmission cost, do we need to be concerned with double, tracking two similar but a little bit different matrices? And then kind of, we know it's inpatient heavy right now, but I think outpatient is going to take us time to come up with. And we've been working to integrate the observation phase in a more systematic way rather than counting the visits in 30 days, maybe do some risk adjustments and including observation cases as if they are inpatient. The other, probably not the short term, but medium term, is to evaluate alternative additional resources. So we put them out there so that you're aware of them. To start with, 3M has a product. Admissions from nursing homes are considered to be potential candidates, and then there are overuse, underuse measures, and Johns Hopkins University School of Public Health and a measure that they developed in their work. And then again, the discussion about what do we do with these. We are always interested in the measurement, but also if you could comment on whether you feel comfortable enough with the measures the way they are right now to have any payments attached to it, or whether you would encourage HCRC to keep that at monitoring level for the first year, is the question. In terms of the considerations that we have on the POUCH is, again, similar to readmission, we are contemplating about positive incentives for improvement. We don't believe you can rank the hospitals on POUCH. And probably, again, it will be with the payment work group for update factor, and we already use them in the population growth adjustment for global budget, which is, again, something that will be better through the payment work group. Just a little bit more context, I was wondering about the overlap between these two measures or different measures, and looking at it, there is not much overlap actually with readmission and PQI, which is interesting, I think. And then that means you need to do both if you really want to reduce the per capita cost. Just looking at readmission is not going to get us there, but at the same time, readmission seems to be the bulk of it. So it's 10%, and 11% in total, and if you add the PQI, it also comes around 10%. So then Allison kind of reviewed the white paper for us and then prepared some summaries. I encourage you to read them all if you haven't done already. And our sense is that probably they will be very helpful in our sessions in March and April when we try to think about an expanded measurement. But nonetheless, I think they are very contextual for this one.
So, just to see our role in PAGA, I mean, I'm a little concerned about readmissions having such a strong spread in multiple measurements that we're basically, but since a lot of the discussion is just the next meeting, where does you plan to start at the next meeting? What decisions do you think that will need to either support or make or recommend to other committees?
So one issue is this observation issue that we discussed in the readmission, whether you think that there should be closer links with the readmission policy that we are trying to get with improvement methodology, whether we should have supplemental measurements within the readmission policy itself, or if it is reasonable to have the top policy, including observation and other ones. The other issue is, since there is so much overlap with readmission policy, maybe we should think about it just a PQI, a similar program on PQI. And then the question is, given there are alternatives there, what is your sense of the utility of PQI from policy improvement perspective? And the state and the governor had a goal, if you are familiar, I think it was end of summer, I got these fancy calls about, well, what is that number? So there is a goal to reduce potential avoidable admissions already statewide. It may also make sense to link up with that program and create a similar readmission program to it. Given that it's a very new one, maybe, then the question is whether you feel comfortable having a payments policy around it will be another discussion for it. So in terms of the admission revisits, I mean, that's exactly what I said. We discussed this before. In the PQI, the other issue with the PQIs is they were originally designed, as you know, as a community level indicator. So their denominator is per 1,000. So how do we take that and put it in a hospital context? And that's why we think there is a payment type of methodology is not reasonable. And if you do an improvement, it's going to be hard to calculate the rate. Maybe we don't have choice but do cost of PQI, and then if you feel comfortable, have some payment incentives in order to reduce that cost for each hospital. Overuse rate.
So this paper may or may not have been posted yet to the website, but it will be soon if it hasn't been already. They submitted this paper, and it's sort of a composite measure that was developed through an extensive review of potential services that were being overly used. They ended up with 20 services or procedures that they looked at, and they used these to create this index. And, they describe it, and I'm just going to try to keep this as brief as possible, as mostly sort of an indirect measure of overuse. But this measure is actually sort of a proxy for overuse. And so in our thinking about it, one of the things is it might be a good screening measure for potential overuse, but it may not be something that we can use for payment necessarily. As it has been developed at this far, more work would need to be done. Also their work was it was done just with Medicare, so the procedures they looked at are just been looking at Medicare. It would need to be sort of validated and developed for an all-payer model. They also did use Part A and Part B claims, so we would have to think about whether additional data sources would be needed to be able to use their measure. And I encourage you to look at their paper, especially if you have an interest in this area.
And we do have an option in April when we discuss. We may bring some of the authors of these white papers to kind of hear from the experts, really. And then there were two other measures that were not exactly in the paper, some of them, and some of them are based on the previous discussions we had, the per capita charge and then length of stay. Even though they do seem to be more efficiency domain, I think it's still important to consider them in this group as well. So I mean, eventually with the per capita stay targets we have, similar to what we do with readmission, if it was easy, it would be very nice to translate that target to a hospital level one. But the question about the denominator attribution model is our not short term, but the immediate, the medium term goal to kind of create that one. So I don't think we are there yet. In terms of the length of stay, that's been used widely, and there are some recent concerns about increasing length of stay. Right at this point, our concern is the impact of the 2 midnight rule. There seems to be a lot of transition going on, and how do you account for that, and also the observation transitions that we discussed earlier. But we do think that maybe it will be still a good indicator for monitoring purposes and flag the outliers and bring them to the red carpet. And then the 3M, potential preventable events.
So 3M has from what they submitted to us, kind of has two products. One they call potentially preventable events, and that includes all 5 of these things: the PDCs, the potential preventable readmissions, potentially preventable admissions, emergency room visits, ancillary services. They also appear to have broken out those bottom 3 into a product they're calling population-focused preventables. And so, again, these are things that we can consider. However, we don't have experience yet with implementing them and using them, and we haven't validated them. So in terms of this year and policy, we have concerns about implementation timing and validation. Also, for ancillary services, it may require non-hospital claims. And I do believe we're having conversations with 3M about these products. And so, more to come, but it may not be ready for where we are at currently.
All right. Miraculously, again, did it actually. Are there any closing comments that you would like to bring in so that we can make sure that the document or the All right, this has been really helpful. I appreciate all the feedback and the comments you provided, and I'll get back to you.
I don't know.
Thank you.
I know.